Dr. Coulter, thank you so much. It's a pleasure to be here to speak with you about this. So I was leaving the house and my wife said, well, aren't you going to wear red? So what do you mean? Said, well, it's the women's symposium, isn't it? So, oh, dang, I ran upstairs and I tried to find a red tie. And the only one I had actually has bombers on it. So it's not actually a very socially conscious kind of tie. So I'm going to talk about cryptogenic stroke and the role of PFO and when we may reasonably consider doing it. You can download this entire presentation at this URL, tinyurl.com, thi-fish.pfo. And the reason you should is because the other thing my wife told me when I gave her this mock presentation is, you have way too many slides. So I did have to reduce the number of slides. I was still pushed to get through all this, but the full complement of slides is available in this presentation in PDF form. I don't have any conflict disclosures, but I do have biases. I was previously the investigator for this procedure with NMT and with St. Jude, now Abbott. So what is cryptogenic stroke? So here's ischemic stroke. This is something you're all familiar with. On the left there, you see the cross-section of an atherosclerotic artery. And down here, you see an open aorta with atherosclerosis in it. And these, by the way, when I Googled this image, and the alt text on it was slice of pizza. So you are what you eat, remember that. So some particles get released from this diseased interior of the artery, and they get propagated through the arterial system, resulting in stroke. Cryptogenic stroke simply is of unknown cause. That is, the typical factors are absent. Usually the patients are younger. Otherwise, they should be in good cardiovascular health, and specifically without central arterial atherosclerosis. Obviously, this requires a search for a less typical cause. The term paradoxical embolism is the description of the mechanism of arterial embolism, and therefore stroke, in the absence of an arterial source. The presence and actions of this must be presumed since you don't get to witness it. Usually, but not always, it's cardiogenic from the right heart and its connections. That means that you have a congenitally present and permissive circulatory pathway. That's because venous inflow is expected to contain particulate matter. In normal circulation, venous inflow is directed from the right heart to the pulmonary arteries, where pulmonary capillaries filter out particulate matter, and these are not conveyed to the left-sided circulation. What's PFO? It stands for patent foramen ovale, said to have been discovered, among others, by Leonardo da Vinci. I don't think he was the first one. Said that he found the channel from left auricle to right auricle. This is the embryology. Looking at the right-sided face of the atrial septum, a septum primum initially grows downward from the top towards the endocardial cushions, and as it continues to grow, it leaves an ostium primum. Ultimately, perforation develops in the septum primum, and that allows the blood flow to be conducted through this hole called the ostium secundum into the left atrium. Then the septum secundum grows, forming a tunnel between the septum secundum and the septum primum. Here in gross anatomy, you can see the atrial septum viewed from the right side. You might think of a hole as being just that, a hole in this septum primum. That would be an ASD. Here is an operative image of atrial septal defect in the septum primum. But we're talking about something else. We're talking about the conduct of blood from the right atrium to the left atrium through that tunnel. The tunnel has a purpose. The foramen ovale in fetal circulation allows for oxygenated blood from the placenta to be conducted from the right atrium into the left atrium because the lungs cannot provide that. The lungs are liquid filled and have high resistance, and therefore blood favors conduction through this foramen ovale. 2/3 of the blood circulation in the fetus goes in this path, then into the aorta where it feeds the body. So how and why does the PFO cause problems? About 1/3 of ischemic strokes are cryptogenic. There are about 610,000 first events in the United States, according to the 2020 statistics. That translates to annual figures of about 200,000 cryptogenic strokes in the United States per year, and far more in the collected area of Western Europe. Nearly 50% of these, that is about 100,000 cases of these patients with cryptogenic stroke, are found to have a conductive or shunting PFO. That means that there may be as many as 100,000 cases of addressable PFO in the United States with cryptogenic stroke per year. Of those, if they're just left alone, 20% will have a recurrent stroke. Here's a case presentation. 57-year-old fit and healthy airline captain with a history of resolved retinal embolus 6 years prior. January of this particular year, he suddenly felt and acted strange. He had receptive and expressive aphasia, improved after about 24 hours with a mild residual problem. His MRI was equivocal and was found to have a PFO with right to left shunting by transesophageal echocardiogram, but incidentally did not have an aneurysmal atrial septum. His hypercoagulable evaluation was negative, and there was no evidence of atrial fibrillation on monitoring. He was classified, therefore, as a recurrent, that is a second stroke event. So in such a case, you would ask yourself, what else could it be? Well, it could be the usual cause of stroke. There's just unrecognized atherosclerosis. It could have been cardiogenic from the left ventricle or from the left atrium, from perhaps atrial fibrillation, or from the mitral aortic valve. Endocarditis or other proliferative valve disease can cause this. Hypercoagulable state may be present, vasculitis, autoimmune disease, IV drug abuse, or some other cause. That's what it means to be cryptogenic. We don't know. But what can you do? Well, on initial evaluation, you should rule out vascular disease and a history of palpitations or atrial fibrillation or evidence of DVT or VTE. Look for recent trauma, recent surgery, occupational problems with compression-decompression cycling, airline captains, deep sea divers, for example, IV drug abuse, vasculitis, recurrent febrile illness that might make you wonder about infective endocarditis, smoking and oral contraceptives. In all cases, a formal neurologic exam should be conducted by a neurologist, and brain imaging must be conducted. The lab evaluation includes electrocardiogram, chest X-ray. If there's plethora or segmental hypoperfusion, then a chest CTA may be indicated. Echocardiogram with bubble study, of course, and a transesophageal echocardiogram if shunting is seen. A hypercoagulable workup is also helpful in all cases. Lower extremity and pelvic venous Doppler may be helpful, especially looking for DVT, May-Thurner syndrome, or in particular to examine the pelvic and uterine ovarian plexi in women. Carotid duplex arterial study, ECG monitoring study to exclude atrial fibrillation, renal function testing if you have unexplained insufficiency. And finally, again, brain imaging. Prior strokes can be multiple and clinically silent. What do you do initially? Stop oral contraceptives, hormone replacement therapy, and smoking. Do not allow occupational exposure to compression-decompression cycling until you know better. You can initiate treatment with aspirin and P2Y12 inhibitors, or warfarin, or direct antithrombins. I think while the evidence is lacking, I think that basic principles would support it. And call a cardiologist who has some appropriate expertise in managing this. The term paradoxical embolism, which leads to cryptogenic stroke, is arterial embolism without an arterial source, presuming right to left intracardiac shunting at rest or with Valsalva. This can be transient or intermittent. Thrombus in the venous system or in the right atrium, for example. Possible factor is there have been cases of thrombus forming in situ in the PFO tunnel. In other words, the PFO enables stroke by means of paradoxical embolism. This little illustration from Abbott.com gives you some idea of what might be going on. Particulate matter enters from the venous inflow, and in one case here, crosses the interatrial septum through the PFO, and then is conducted by the left heart into the arterial circulation. If one of the organs that can be struck by this, of course, is the brain, and this produces infarction. Who has PFO? Well, in the normal population, it's really extraordinarily common. A lot of the people walking the planet will have it, as much as 25% in the Mayo autopsy series. So if it's that common, you have reason to ask, is it really implicated in cryptogenic stroke? Well, if you look at patients who are younger, less than the age of 60 years, younger patients are far more likely to have PFO. And depending on the baseline incidence that you accept, it may be as much as 5 times higher. This is a sort of a post hoc implication that PFO is associated with and potentially causal for cryptogenic stroke. Well, then, does it really need to be treated if it's so common? For many years, we had only sort of circumstantial evidence that it was that treatment was helpful. And in the best meta-analysis of a lot of smaller studies, in the Canadian Cardiovascular Congress in 2003, it was reported that transcatheter closure was associated with a 65% reduction in yearly incidence of stroke, or TIA. And while this was a long time ago and was not a prospective randomized trial, it turns out ultimately to have been right on the money in terms of predicting how effective PFO closure would be. So in the case of our pilot patient, in about 2006, these were the sort of ideas that we had to use to judge whether it needed to be closed. If the patient was asymptomatic, if the patient had significant risk elements such as a hypercoagulable state, a septal aneurysm, recurrent or significant VTE, or even migraine with aura, or with an occupational hazard such as pilot or deep sea diver, we would consider it quite strongly, even though it was not sanctioned at the time. If someone has been symptomatic and had a first event, oddly, we were not actually licensed to go ahead and treat those patients. We had to wait for their second event. However, in the given latitude as we were judging clinically what would be helpful to the patient, if the patient, even without risk elements, had such a first event, we would think, yes, maybe we should. Nowadays, we know that we absolutely must. If they had risk elements then, we probably would, and with occupational hazard, yes, we would. If they had a recurrent event, namely a second event, then we were allowed to absolutely to proceed in treatment. So what options are there? We basically have the option of anticoagulating the patient for life. We used to say you could close them surgically as they used to be done, but that's no longer the case. And now transcatheter closure of the PFO is the favored form of therapy. Medical management was of uncertain value and spotty in many respects. Warfarin was possibly protective, but only in cryptogenic stroke. Everything was sort of non-randomized, retrospective study, and it was hard to know what the actual recurrence rates were. But when you look at patients with good diagnostics, including TEE, you found that among those patients, they had a very high incidence of PFO if they had a cryptogenic stroke. In the mouse trial, it was found that the combination of PFO and an atrial septal aneurysm represented a high risk for recurrent ischemic stroke, even on aspirin therapy. And of course, anticoagulation for life has a lot of risks. I won't bore you with all this, but in this particular study of more than 500 patients starting on Coumadin, over a period of 46 months, the cumulative risk of major bleeding was 63% in the high-risk group, And while it was only 2% in the low risk group, any risk factors produce rapid escalation in the risk of bleeding. So here's the device we use today, mostly in the United States. In Europe, there are other approved devices. This is the Amplatzer PFO occluder. It's made out of shape memory nitinol wire in a weave that allows it to form two umbrellas that can be put in, deformed into a spindle shape and inserted through a catheter. It's quite an interesting invention, and it was invented by Kurt Amplatz, who died just last year. He is quite the innovator in this field, invented many things that we use commonly, the Amplatz catheter shape, the number of things like the Amplatzer device, including vascular plugs and snares, arterial snare devices. So this is the animation of how the closure is done. The catheter is put across the interatrial septum through the PFO tunnel. Left atrial disc is deployed and brought up against the left side of the septum. And then the right atrial disc is deployed. And once you're satisfied everything is in place, you release the cable and the device is there permanently. Over time, in about 3 months' time, tissue will grow over the device and it becomes passivated to the circulation. So going back to our guy, he's classified as a recurrent event and he was done. This is the initial transesophageal echocardiogram going from the right atrium to the left atrium. You can see the bubbles crossing. And you can appreciate the tunnel here between the thin septum primum and the thicker septum secundum. We took him to the lab and we put this device in. It's called the CardioSeal that we don't use anymore. The company went out of business. Don't have time to go through his case completely. I want to discuss a more illustrative case. This is a case of an ASD and a PFO together. Here you can see a septal aneurysm that is very thin and very mobile interatrial septum. There was a secundum ASD previously identified by echocardiography. But here you can see the respiraphasic movement of the septum. And in the phases where the thoracic pressure is decreased, you can see blue flow going across from right to left. Here it's more dramatic, respiraphasic flow going right to left, that blue on color Doppler, hypermobile septum. But where's the ASD that we knew about? Well, here is the ASD. You can see that red flow indicating left to right shunting in the other direction. So we have essentially bidirectional shunting as a result. Here's the wire passed through the PFO, but because of our particular strategy, we're going to close them both by a single device placed through the ASD. So now the wire is repassed through the ASD. That's what's really needed in this case. You can capture the PFO also with this device. Here you can see the wire placed well through the ASD. And this is the use of a sizing balloon. We don't always use this to help us figure out the correct size for the ASD. Now with the catheter across the ASD, it distorts the septum, so it kind of aggravates the shunting in both directions. ASD from left to right, that's the red flow, and from right to left, that's the blue flow through the PFO. Here's the left-sided disc deployed. Bring that up against the septum. Deploy the waist into the ASD. Deploy the right atrial disc. and which is both defects. Color Doppler, there was no residual PFO shunt. The upper rim is capturing the septum secundum. Therefore, the PFO is closed. How is the patient managed? Get SBE prophylaxis for 6 months, anticoagulation or P2Y12 inhibitor with aspirin, chest x-ray at 1 and 6 months, echocardiogram in 1, 3, and 6 months, and monitor for atrial arrhythmias. It occurs in some form, usually mild or paroxysmal, and about 15% is usually self-limited and resolves after about 3 months when the tissue is grown into the device. So what do we know about the outcome? For a long time, we didn't know enough. There were some initial studies that were small that indicated that closing the PFO reduced the risk of recurrent stroke. And I told you about the Canadian Cardiovascular Society meta-analysis that indicated it did a substantial job of that. But then the definitive trial was done. It took more than 10 years. And that was the RESPECT trial, published in 2013, but with incomplete results. And the later final results with the Amplatzer device was ultimately published. Final results of the RESPECT trial. You know about all of this background. This was a 1-to-1 randomized trial between the Amplatzer closure device and guideline-directed medical management in almost 1,000 patients in 69 sites in the US and Canada. Primary endpoint was non-fatal ischemic stroke, fatal ischemic stroke, and early post-randomization death. Key inclusion criteria was the stroke had to be within the previous 6 months, 18 to 60 years of age. Key exclusion criteria, stroke due to something I identified was clearly due to atherosclerosis, so those people would not be included. And people who needed to be anticoagulated, for example, for atrial fibrillation, were not included. Most of the medication was antiplatelet therapy, set by 80%. And here are the final results. In the intention to treat analysis for all recurrent stroke, the risk reduction was 45%. Now, in cardiology, when we get risk reductions of 15%, everybody is excited and we start treating everybody. 45% is pretty impressive. But if you look at cryptogenic stroke alone, recurrent stroke was reduced by 62%. And then if you looked at the high-risk cohort, those who had a substantial shunt or an atrial septal aneurysm, the risk reduction was 75%. Pretty compelling. They support the hypothesis that the PFO closure is preventing PFO-related strokes. The other thing that was found was, of course, PFO closure with this device, a permanent metal and plastic device placed into the heart, was incredibly safe. There were essentially no interprocedural central cardiac events, no thrombosis, embolization strokes, no device erosion over time, and the vascular complications were less than 1%. In conclusion of that trial, it was more beneficial than medical management alone. For patients with cryptogenic and stroke, and PFO closure was very effective in it, as then thought to be a primary form of treatment for PFO. Well, it wasn't the only trial. There were other trials concurrently going on and since, and subsequently these trials collectively all showed the same thing with risk reduction of about 70 to 75%. Therefore, the European position paper in 2018 for those patients who have had cryptogenic stroke thought to be secondary to PFO, without other etiologies identified, percutaneous PFO closure was recommended. I don't have much time. There's some stuff in the presentation about PFO and pregnancy, but the take-home points include that the transient hypercoagulable state in pregnancy that you've heard about can increase the risk for venous thrombosis and therefore for ischemic stroke in the presence of the PFO. There's no clear consensus about how you manage these people. It is thankfully a very low incidence. There have been attempts to provide a stratification score that would tell you if the patient was high risk or low risk, but as I've read that literature, I don't have much faith in that scoring system. The presence of an atrial septal aneurysm or a large PFO may be associated with increased likelihood of paradoxical embolism, but it's controversial. So conclusion, PFO is a pathway for embolic stroke, especially in young patients. Initial evaluation includes a number of things, including a formal neurologic exam with brain imaging. The interatrial septal aneurysm seems to be associated with PFO and a higher likelihood of stroke by paradoxical embolism. Originally, closure was indicated after recurrent or the second stroke, but now indicated after the first cryptogenic stroke. Device therapy is directed to reducing the recurrence of stroke. PFO by itself, in the absence of stroke, does not actually warrant closure. Catheter devices are very safe, effective, and approved method to provide PFO closure. Patients with migraine and PFO may be helped by PFO closure, but specific criteria are lacking data support yet. PFO and pregnancy may become an important issue. Data are lacking. So here's some study questions. A PFO is a hole in the septum primum. A, true. B, false. It's false. A PFO is a tunnel formed by the septum secundum and the overlying septum primum. An ASD is a hole in the septum primum. 2, characteristics of cryptogenic stroke include age less than 60, absence of atherosclerosis, and reduced by device closure, but not anticoagulation. 1, 2, 1 and 2, 2 and 3, all of the above. I'm not going to make you commit. Not putting anyone on the spot. The answer is C, 1 and 2. Both device closure and anticoagulation will reduce recurrent cryptogenic stroke, but device closure does it better. Study 3. In the fetal circulation, 2/3 of the blood entering the right atrium shunts through the open foraminal valley and 1/3 passes to the right ventricle. True or false? That's true. The blood entering the right atrium contains the inflow of oxygenated blood from the placenta that is then distributed to the arterial circulation through the foraminal valley. Number 4, post-procedure management after PFO closure includes SB prophylaxis indefinitely, a requirement for warfarin therapy, 3, monitoring for ventricular arrhythmias. None of the above. SB prophylaxis is recommended for only 6 months. Antiplatelet therapy may be given instead of warfarin. Atrial arrhythmia may occur, but ventricular arrhythmia is not expected. Last one. In the RESPECT trial, recurrent stroke of unknown mechanism was reduced by device closure by approximately 45%, 52%, 60%, 75%. 60%. So by the intention to treat analysis, the relative risk reduction for recurrent cryptogenic stroke was 62%. For all stroke, the reduction was 45%. And for those with substantial shunt or an atrial septal aneurysm, it was 75% for recurrent cryptogenic stroke. Last study question. This presentation can be downloaded in PDF format. Yeah, all right. Yeah, I should have put it under that URL, but no, it's the Okay. Well, I don't make, 25% of people walking the planet may have PFO. It's not by itself evil. And we have to remember that PFO has a purpose. That is, the foraminal valley has a purpose. This is why we have a foraminal valley. This is my granddaughter at 28 weeks, and she's using her PFO. Thank you very much.